Okay, it's my great pleasure to be here to share with you our experience in the using NGS for treat our non-small cell lung cancer patients. Let me see. Okay, so the definition of precision medicine actually is we all know that not like previously the way we treat our patients. Some 10 years ago, we still treat our patient based on the clinic trial evidence. So that we, for example, we put our adenocarcinoma lung cancer patients with pemetrexed and protein, and squamous cell carcinoma with gemcitabine or taxane plus protein. But then we moved to the targeted therapy that after the find out of the EGFR TKI. So at that time, we selected patient for use of EGFR TKI. But for the patient without EGFR mutations, we still have to put them on the chemotherapy. But nowadays, we have NGS. Use NGS, we can find out the different driver genes at some times, particularly at diagnosis. So that's different from the so-called target therapy. At that time, we treat selected patients. But this time, with application of NGS, we can selective treatment for the patient, for every patient, from the beginning of the treatment. So in my mind, the precision medicine have three essentials. One is we have to have valid biomarkers so that we can have the target to treat. And then should have a platform that's NGS, so we can detect every trackable or actionable genes that we can treat it. These genes will help our patients. And finally, we now can apply liquid biopsy so that we can monitor the treatment course at a different time point to follow the change of disease course. And nowadays, we know that for non-small cell lung cancer, we at least have two tests for treating the non-small cell lung cancer patients. One test is to detect the driver genes, and the other test is to use test the PD-L1 for the patient whose tumor has no driver genes. So that for the first-line treatment for patients without driver genes, when we test PD-L1, the patient who has higher expression of PD-L1, immunotherapy is standard of treatment. But if they have no PD-L1, then chemotherapy should be the standard of care. For the patient with driver gene, we all know that targeted therapy is the treatment of choice. These driver genes included EGFR, ALK, ROS1, BRAF, and recently NTRK. And once this patient treated with targeted agent failure their first-line treatment, then we can detect the resistance mechanism, resistance gene, and treat with next generation TKIs. Once the standard of care becomes chemotherapy and no more targeted agent available, then the chemotherapy will be the standard of care. And also for the patient who have no driver gene and have a low expression of PD-L1, and their standard of care is chemotherapy. But at this time, we can add immunotherapy, and otherwise can move to second-line immunotherapy. And for the patient with high PD-L1, of course, you can add chemotherapy to enhance the treatment outcome. So in the NCCN guideline, this I just mentioned two tests. One is molecular test, one is test for PD-L1. For molecular test, we can test EGFR or KROS1 BRAF and track. But I highlight here with red color is that in this guideline, it's mentioned that testing of the molecular gene should be conducted as part of broad molecular profile. That's the spirit of precision medicine. So should test them all together at one time. So when the patient is diagnosed as non-small cell lung cancer, then we should test the sample for these drivers and use this detected driver gene to treat the patient. And once the patient treat with the right drug, then we have to monitor clinically with image or with tumor mark or with functional image or CTG or even circulating endothelial cells. And once the disease progresses, we have to do it again, and particularly selective rapid growing part of the progressed tumors to do the genetic test and to selective to find out the disease mechanism, then pick up the right agent to treat this case. So the function of NGS or application of the NGS in precision medicine, at least I have three functions. One is I just mentioned is that we can find out the driver gene and put on the right treatment. And sometimes we can find out there are a small percentage of patients. These genetic change are not exactly mutually exclusive. 4.1% of the patients have double mutations. And the most important thing is that we can find some associated genes which can modulate the selective targeted therapy. For example, in EGFR mutation patients, if they have a co-occurring mutation of TP53 or KRAS, this associated gene will have a negative influence on the treatment outcome of available EGFR TKI. For example, if the patient tumor has P53, then the survival curve is much poor than the patient who has not this kind of associated mutations. So if you have no NGS applied and the incidence of TP53 is only 8% of patients that you can find. But with the application of the NGS, you can find 48 patients. That's 6/4 of patients. You can find that. So before the treatment, you can figure out this patient adult whose tumor had EGR mutation, but the treatment outcome is relatively poor. Some years ago, we published a paper that we found MLH1 V3A4T polymorphism associated with poor response to EGR TKI in patients with LA5AR positive lung adenocarcinoma. So in this particular paper, we also confirmed that these patients who have P53 mutations have poor outcomes. The patient who survive, whose progression-free survival period less than 3 months have a more chance to have this kind of P53 mutations. And P53 notorious for poor outcome, not only for poor response treatment, but in patients who have P53 and also RV gene mutations, they have a higher chance to have small cell transformations. So in these particular patients, if you can find out RV gene and TP53 co-occurring in their tumor during the treatment with EGR TKI, once disease progression, you have more aggressively to do lung biopsy instead of liquid biopsy, because they have a higher chance to have small cell lung cancer transformation. But TP53 is not so bad. Sometimes it have a good guidance for immunotherapy. For example, if TP53 have a co-occurring mutation with KRAS, these kind of patients are more likely to respond to immunotherapy, particularly immune doublet, use anti-PD-L1, PD-1 plus anti-CTLA-4. That's this kind of double genetic change. Suppose this tumor has a higher chance to express higher level of PD-1 and of PD-L1. Okay, so in this slide, the left column, you see that's the patient who are TKI naive patient. And with the treatment, after the treatment, the molecular change is getting more and more with first-line treatment or post-first-line, second-line treatment. You can see more and more of genetic changes. But I highlight here is that you see the very last column. You can see that's the great. This column is that patient with exon 19 deletion. And the great column here is the patient with LA5AR mutations. You can see that the patient with LA5A mutations have more aversion of genes, more genetic change. This is probably the reason why LA5AR mutations have relatively shorter progression-free survival when they treat with EGR TKI as compared to the deletion 19 EGR mutations. And also for the osimertinib treatment, the left column is sensitive cases, and right column is non-responders. You can see the non-responders have more genetic alterations when compared with the responders. And most of these genes only happened in the non-responders. This included some DNA repair gene and cell cycle pathway genes. So if you can do NGS before your treatment, you can find out EGR mutations, you can find out the associated genes which can influence negatively of the treatment outcome. So you probably can figure out how long the patient can respond to the treatment you used. And but the most important function of the NGS, I think, is that you can correct the patients who have very rare mutations and register them and correct them. Once the drug company develop new drug for this actionable gene, they can enroll enough patients to promote the development of the new drug for this actionable gene. The very famous trial is the NTRK study. NTRK genetic change happened in many kinds of tumor. In this particular study, lorlatinib was tested in 55 cases of 17 unique cancer types. And that's the enrolled period with the help of NGS only 2 years. So without NGS, we cannot figure out probably more than 10 years to achieve the same result. So it's very helpful with help of the NGS can promote the new drug development. And now I like to share with you our experience. Previously, that's some 2 years ago, we start to do NGS for our patients. Most of the tests we did for the patients who have disease progression when they treat with EGR TKI or other targeted agents, and then try to find out the resistance mechanism and selected the right drug for treat the patient when they fail the first-line treatment. And the second most samples we send is that when the patient initially diagnosed with non-small cell lung cancer, particular adenocarcinoma, but initially they cannot find to have OC of EGR mutation. That's in Taiwan. These two genes are reflect test. But sometimes the patient is younger and female, never smoker. And we always try our effort to find out probably some driver gene there. So we also included this patient. We suggest them to do the NDS. And the third group, but few cases, is treatment-naive patients that when they diagnosis, we try to suggest patient to receive this kind of examinations. So we consider a lot about the why a lot about what and how to perform this kind of examinations. Of course, tissue is a major issue. Although we can do liquid biopsy, but actually tissue is and plasma, liquid biopsy, they are complementary. But tissue, in my mind, is much more important than the liquid. Liquid is important for follow-up the treatment course, but initially, I think tissue is very important, more important. And the second one is how we selected the panel tested. Lung cancer is most of my patients are lung cancers, and which target you like to see, and the patient's treatment history, and I want to test tissue or liquid. Is that possible to get the tissue, or we can only have the liquid biopsy? And the test company is local or abroad. If we have to send a sample abroad, that takes time, and also quality of control is also a problem. And of course, cost of test and drug availability and the cost of drug, particularly in Taiwan. We have, for the drug approval is a little bit slow than Hong Kong or Macau. And finally is the patient, if the patient have chance to join the clinical studies, particular global new drug clinical studies. So we selected, we have 3 options. At that time, the most simple one is ACT monitor. But we test only 11 genes. That's including the all lung cancer, most frequently happen gene and or bypass pathway genes. That's 11, and these are liquid biopsy. So it's much more easier to get a sample to do the test, and also it's cheaper. And the second one is a drug. It's test about at that time 35 genes and test tissue sample. And the gene list is here. And of course, for some rich patients, we selected the ACT-on course. That much more expensive, more than double of this one, but included a wide spectrum of oncogenic genes, and also included TMB. That's probably helpful for guiding immunotherapy. And from 2016, February to 18 September, we tested 267 samples from 202 patients. So that's actually at 4 different hospitals. So I have clinic at these 4 hospitals. So the hospital, most of the patients at downtown area, they are a little bit rich, so they can afford this kind of examinations. Okay, so among these 202 patients, they have these samples. So 3 out of 4 patients have only 1 test, and 25% of the patients have multiple tests. And for the patient have only one test, 108 have plasma, 36 have tissue, that's 3-to-1. And 7 patients have one test for CSF. And 4 patients have, we have 5 patients receive 4 tests at a different time and with different samples. And 4 patients have three tests, and 42 patients have 2 tests. That's 42 patients here, so that some patients have a different sample at the different times. Some patient has the same sample at a different time, and some patient with different sample at the different, at the same times. So that's the background of our patients. So for the patient, treatment-naive patient, we have 10 patients, 4 with tissue and 6 with plasma. We can detect EGR mutation, rare mutation like G719A and LA58P and KRAS and P53. And for tissues, 1 patient have EGR G719A, this patient, and also have ARC amplification and have mTOR pathway. This for treatment-naive patients. But for the patients who were treated before, most of them are EGFR activating mutations, including uncommon mutations, account for 64%. That's, we have 70 patients with 78 samples. And we can find that is very, like you read in the papers, that we find mTOR, KRAS, MET, exon 14 skipping, those 1, ERB2, ARC, and BRAF. That's from tissue. So the sample with at least 1 variant detected is 93.6%. And this slide shows the patient who have received the first and second generation TKI treatment, and also EGFR wild type patients. So in EGFR wild type patients, you can see some of them can find other driver, for example, BRAF. So in these patients, 13 patients found out to have 790M acquired resistant mutation, and 4 patients with MET amplification or exon 14 skipping. Now, number in the here the patient treated with targeted agent. So for these 13 patients, 12 treated with osimertinib, and these 4 patients, 2 patients have been treated this anti-MET inhibitor, and we have detected 4 ALK fusion patients here and treated with ALK inhibitor, and 1 with dose 1 fusion treated with entrectinib followed by quizartinib, and 4 patients with BRAF and receive BRAF and MEK inhibitor, davarafenib and trametinib. And we have 3 patients with ERB mutation and purification. These patients receive chemotherapy, and mTOR pathway also chemotherapy. So let's have this kind of results do some helpful for guide our patient treatment. And here is the 20 patients, 25 samples. This patient already treated with third generation TKI osimertinib. And you can see I highlight here is the patient with T790M acquired mutation. And some patients after treatment will lose T790M. But when they develop resistance, some of them found out to have C797S. All these mutations are called mutation with T790M there. And if their T790M disappeared, as you can see here, this patient, when they resistant to osimertinib, they lose their T790M. So as previous many report that this patient have second bypass pathway. So you can see that have MET 5 patients and 4 patients receive anti-MET treatment and 1 red fusions. But this patient has no chance to receive treatment before he died. And 4 patients have mTOR, and 10 patients have cycle genes. But all these bypass pathway. And these are liquid biopsies. You see the more patient, you cannot find anything there. So the detection rate about 57.5%. So 1/3 lower than the tissue. And for some patients, that's liquid biopsy. The patient who have received osimertinib treatment, you can see very similar findings. And some have T790M detection in the patient who still have C797S, they still have T790M. And one patient, we found out it's about OC fusion. That's mutation, actually. And it's not the resistant mutation we see in the OC patient who receive anti-OC treatment. And one patient from CSF also, we found some bypass pathway. And this one, we found the OC in his CSF initially. He is not a patient with OC transformation. But after osimertinib treatment, we detect OC in his CSF. And this patient received ruxolitinib for 7 months. And from the very confused and inadequate mentality to he can walk around and very easy to communicate. And some patients here, we have 21 patients who have liquid and tissue, both samples. And you can see the red part, that's the column, the different individuals. And the red part are detected, the gene detected both in tissue or liquid. For example, some EGR mutations are detected in both tissue and liquid. And the blue column only tissue only. You can see more blue column spread in these different genes. And only few patients, they have both tissue and plasma, but the gene detection in the plasma, for example, OC mutation. This case is very interesting, is that this is OC patients. The OC transformation detected in tissue, but acquired mutation detected in plasma, and the P53 detected in both tissue and plasma. This patient have the OC transformation detected only in tissues, but have the different variant of acquired mutation detected in the plasma, particularly G1202R. These are gatekeeper resistant mutations. This mutation is resistant to quizol and also aratinib, and partial resistant to serotinib, and sensitive to brigatinib, but more sensitive to lorlatinib. That's with selective lorlatinib for this case. You can see that after treatment, the polarization here is decreased with time, effusion down to here. And the other view, you can see effusion up to here, and after treatment, the effusion decreased. And this is another guy who has OC mutation. You can see he previously treated with every kind of anti-OC treatment, quizol, serotinib, and also aratinib through his treatment course and disease progression. And we found out in the plasma that the resistant mutation, G1202R there, that's the only one mutation at that time can be detected in his blood. So we treat with lorlatinib. That's before treatment. You can see the very huge axillary lymph node, liver metastasis, axillary lymph node here, liver metastasis. And after treatment for 1 month, the axillary lymph node decreased in size. And this PR and also liver have a very good response. And the before treatment and after treatment, you can see the liver also tumor significant regression. And this is old lady that she previously without any driver mutation found it, and she received chemotherapy, neoadjuvant, and then surgery, and then adjuvant, although it's a 3B with neck lymph node metastasis. So after treatment, the neck lymph node appears. But after surgery, 8, 9 months later, the lymph node relapsed. So we give her radiotherapy, and then relapse again. So put on erlotinib. At that time, erlotinib can be used in wild type second line in Taiwan. So, but the duration is very short. So switch to immune monotherapy. Why the PD-L1 is between 1 to 59% monotherapy. Because at that time, we still have no data of chemo combined immunotherapy. So we put on Irisa plus Taxol. And after 2 cycles, PR, but have liver toxicity. So we switch definitive to erlotinib, also plus single agent Taxotere. That's so-called Laxlang-5 treatment, but we use erlotinib, not afatinib. This give her more than 1 year survival, and then PD in higher lymph node and lung to lung meta. So we do the biopsy and NGS and find out a very rare BRAF K601E mutation. These are not V600E mutation, very, very rare. So we have no idea, and the searching the article have only a couple of cases without definite treatment outcome. But we put her on davarafenib plus tremetinib. That's standard of care for BRAF V600E. You can see here is not only 1 month's treatment, the tumor shrinkage significantly. That's last year, and the treatment outcome is very good. The patient is still alive and no relapse at this time. And here another case is ERISA treat developed T790M. Then we put on afatinib. Suppose it have, for example, 16% for T790M, but it's failed very quickly. Then switch to osimertinib. After after about 2 years, osimertinib is failed with lymph enlargement. So we do the biopsy and do the NGS and find out c-MET amplification. So that with this result, this patient was put in the TATON study of AstraZeneca that combined osimertinib with savolitinib. You can see that the response is very quickly. That's within 2 months, the lymph node disappear. The lymph node is disappear. And this patient now is still alive. And this another old lady who diagnosed as non-small cell lung cancer 12 years ago. And after operation and relapse, that's erlotinib neoadjuvant, followed by surgery. Then relapse treated with ERISA, chemotherapy, and chemotherapy, Avastin, then afatinib, then developed T790M, osimertinib, enrolled in the ORA2 study for 3 years. Then after failure, found out it has EGFR amplification. And at that time, we try to, or the patient ask for immunotherapy. So we give her some shot of Keytruda, but no effect with elevation of tumor marker, and also you can see more lung nodule here. So we switch back and put the double dose of osimertinib. But you can see that's only 4 weeks. The patient have rapid progression. So we remember he has EGFR amplification. So put on single dose, regular dose osimertinib plus Erbitax 250 milligram per body square meter Q2 week. And you can see that the response is very quick, and the last for a long while. That's for about 7 to 8 months of this kind of treatment. This one is the last case. I'd like to show you this actually is a young patient, was born in 1973, who have brain metastasis at the diagnosis. So, but the tumor has EGFR mutations. So he was put on ERISA, followed by pulse therapy of Tarceva with some effect. but very young. The brain is, the tumor in the brain is very close to the gyrus. So we led him to receive whole body radiotherapy because his primary tumor can be controlled. And then switch back to ERISA, Tasiba pulse therapy again, and do biopsy or try to find some resistance marker and do gamma knife. And finally, we do the PET, but cannot find anything. But 1 month later, do the MR and find that there is a progressive lesion in at the adrenal gland. So do adrenal biopsy, 790M positive. So he was enrolled in the ORA osimertinib trial for about 1 year, relapse, but no c-MET. So even with lung resection. And so that enrolled Tatong trial to use combination with anti-MEC treatment. And this combination was work and last for about 10 to 11 months, then fail in the brain and the lung. So he received immunotherapy with immune tablet, but not useful. And you can find the brain progression, and this patient have fever, cannot concentrate, headache, and cough, and dyspnea. And then we do the lung biopsy again. And in right order, just only EGFR 3 copies. But in his medial standard, do know we found some MET high copy. So we put him on the double dose of osimertinib for brain penetration and add quizartinib, 250 milligram BID. That's the October 24th. So that's only 2 weeks, less than 3 weeks. You can see the brain shrinkage, the tumor getting smaller and smaller. And no more headache, no more fever, and the lung lesion is getting much better. So this patient have a chance to went to Japan for 2 months vacations. But you know, the drug every month is 1 million Taiwanese dollars every month. Very expensive treatment. So this is the last slide. Nowadays, with the help of the NGS, we can treat our patient at the right directions and with the right drug. So particularly at the right times. So now, of course, to detect the resistant mechanism, NGS is very helpful. So this group of patients is very important. But we hope that NGS can be pushed to the diagnostic stage. At the initial diagnosis, the patient, I try to do my best to persuade the patient to do the molecular test. For example, the patient who has BRAF very rare mutation, if we can find this kind of genetic aberration at the beginning, he probably not had to receive so many treatment, including chemotherapy, surgery, or and also radiotherapy. And we'll have many patients who no need to receive and effective treatment. My talk is ended here. Thank you very much.